Thanks, AJ. I'm going to start by disappointing Patrick with the admission that when I was at school, I really struggled with maths. There was no question of any tuition being affordable, so my poor father, decided that he needed to give me extra lessons at home. I don't really remember much about the lessons or indeed whether they're helpful at all. But I do remember the first one because he sat me down at the kitchen table and he made me write out his golden rules for maths. And the first one, those of you like me from the pre-calculator age will appreciate, was keep the columns straight. The second one is, if there are any epistemologists in the room here that will appreciate, was don't give up what you know for what you don't know. And then the third rule was you will always continue to be hopeless at maths if you continue to believe that you are hopeless at maths. So a very unconventional teacher there. But it's been a long time since I've last multiplied a pair of 4x4 matrices. And my intuition as a child that wasn't going to help me as an adult has proved correct. And if anyone wants to disapprove that, see me later and explain. But I've always been really interested in that whole relationship between beliefs, what you believe, what you do, your behavior, and how you perform. And I'm particularly interested in the subset of beliefs that the economist J.K. Galbraith talked about, being conventional wisdoms, which are the beliefs that are so widespread and so deeply held that they're kind of like an invisible backdrop in our lives. But when you examine them, when you put light on them, you often find that they're not actually correct, and that they lead to a set of behaviors that are holding you back. And if you start looking for them, then you kind of see them everywhere. And so for me, with something as challenging as the question about how do you use innovation to reform the NHS, I start from the question of, well, are there any of those beliefs? And I think that's a personal question for all of us as to, are there things that we've believed about innovation that really aren't necessarily true? They're perhaps conventional wisdoms. So, and as context for that, we've probably all nodded sagely at the following narrative about innovation, which is that the NHS has a very low appetite for risk, and actually you need a high appetite for risk in order to experiment and fail. That trying to drive things too centrally doesn't really work. You need to create the environment where people feel that lots of experiments are worth trying and let 1,000 flowers bloom. And that the real issue, people are crying out for innovation, but the real issue is there's a huge degree of, or a huge number of barriers to supply, and that we need to find our ways around those barriers to supply. And I'd like to argue that the beliefs behind those are not only wrong, but they're the exact opposite of the truth. So bear with me on that. I'm going to start with the issue of risk, which was referred to a bit in a couple of the conversations this morning. So we're very used to the idea that the NHS has a very low appetite for risk. And that's such a barrier to innovation because you do need to fail and you do need to experiment. And it does seem that when you're trying something new, then the appetite for risk is very, very limited. And I'll give you an example that I'm familiar with. I chair a company called Skin Analytics, which is an AI diagnostic provider in dermatology. And we now have in this country regulatory clearance for autonomous use, and we have independent validation that it's better performance than the average dermatology in terms of sensitivities. And it's been used on 120,000 patients. It's been validated on over 30,000. So there is still a strong desire for a second read, and perhaps that's understandable. And when you do a second read, you find that dermatologists overrule the AI decision 30% of the time. So 30% of the time they think the AI is wrong. But if you look at the number of times that they do overrule it, the actual times that they get that correct to overrule it is 0.4%. Okay, so they overrule it 250 times, one time they're correct. Okay, and I can't think of a better example of how powerful the concern about the risk of changing the way of doing things is. But if you look more closely, I think it's hard to see that that's born of a more generalized aversion to clinical risk. And Ian talked about this a bit, which is, if according to NHS data, between a third and a half of the most serious skin cancers are found in the routine waiting list, not in the urgent waiting list, but in the routine waiting list. And there are 450,000 people today waiting on the routine dermatology waiting list, which means that it is highly likely that today there are 5,000 people in the country who have invasive melanoma or SCC, both dangerous cancers, which we will get to find when we get round to it. That's a major reason why 3,500 people are still dying from skin cancers every year in the UK, even when it's one of those areas where early detection means almost always good outcomes, fully treatable. So I don't know about you, but I think that's an awful lot of clinical risk that's being held in the current way of doing things. And the pattern holds across specialities. So if you sort of zoom out and look at mortality risk within just the hospital end of the spectrum, since as long as we've been measuring it, there's the difference between the average mortality risk and the best performers, many of whom are in London, but not all, is about 20%. And as ever, kind of percentages kind of hide real people. If you think about what that means that somewhere between 40,000 and 50,000 people are technically dying avoidable deaths in hospital. Avoidable because we do actually know, and we can prove that we can operate at a higher level of clinical performance. And that's an airliner crash every day, all year, every year. And I suppose if you were to look more broadly at that, we know that most of the mortality and morbidity risk is way before the hospital system. And you look at, if you look at things from that perspective, you'll find that you're measuring the risk in literally millions of years of disability-adjusted lifespan overall. So I often find NHS colleagues getting very, very concerned about something new potentially going wrong, and thereby sticking to a model which, if we're honest, has already gone seriously wrong. So while it might seem that we have a risk aversion problem, I think we have a risk asymmetry problem. And while it might at first appear that we want the NHS to have a higher appetite to risk, I would argue that what we really want is for the NHS to have a much, much lower appetite for the risk that it's already sitting on. So that's the first brief I wanted to talk about. And the second one is this: you can't drive innovation top down. You have to let 1,000 flowers bloom. And I was nodding in agreement on this to what Tim was saying before. It's very closely related as a belief to the belief that place is so important in healthcare that the priority is to enable tailoring to place when you're doing innovation. And these are such critical beliefs for the NHS that the NHS is organised around it. And I think when it has discretionary money to spend on innovation, it tends to be very fair to everyone because of it. So it splits the money up and gives it a bit to everyone to be fair to all, even if that means small ticket sizes. But I've come to believe over time, having nodded at that belief for a lot myself, I've come to believe that that doesn't survive contact with three facts. And the first one is that scale is the lifeblood of innovation. All too often, because funds have been parcelled out in a way that's fair to everyone, and they're small, and because it's really hard to get going with any innovation in the NHS, we end up with very small-scale experiments which don't have the scale to demonstrate that they warrant being scaled up, or that they really could work in other contexts. And investors will obviously tell you that unless there's a route to scale, they're not going to put their capital in. Secondly is synergy. Synergy is absolutely vital to innovation and its impact. We all know that if, for example, we make primary care easier to access, then if you do nothing else, you'll just create more people coming. We also know we make it harder to access, and you do nothing else, people will go to ED. It's squeezing the balloon one end and it's expanding the other, and that's the way the healthcare system works. So individual initiatives or innovations have a very limited chance of affecting total system change and therefore having impact unless they work in concert with each other. And the only innovations that really are going to transform our healthcare are ones that operate both at scale and in synergy. So in that example of primary care, if you were to also make more prevention available and more self-care, and more support to self-care, then actually increasing access to primary care might work. And I think, thirdly, I think we've overstated the importance of place in innovation. And that might be my biggest heresy of this particular talk. If you think about it, the determinants of health are pretty much the same everywhere. The biggest killers certainly are the same everywhere. Drugs tend to work tend to work in one place versus another. Likewise, lifestyle interventions, likewise surgical procedures, etc. That's not to say that place, and in particular working with local stakeholders, isn't vital to tailoring the delivery of healthcare, but it is to say that to start from the presumption of difference rather than similarity may not really be tethered to the facts. And indeed, most of the really exciting health innovations tend to be ones which are able to personalize at scale across multiple geographies. So in a world of constrained resources, the let a thousand flowers bloom concept of innovation has no answer to the scale, synergy, or place challenges. And I think if we're honest with ourselves, it's really a license to let a thousand flowers wilt. And then the third and final belief that I wanted to go through is the very deeply rooted belief that people are crying out for innovation, but the problem is all the hurdles to supplying it. Procurement, contracting, data, IG, various governance levels, various approval levels, interoperability. I mean, a huge list of issues. And any entrepreneur here will know that in their experience, those hurdles are really very real and very difficult and very painful, very frustrating. But I'd like to ask the question, if I were to say to you that you give me 0.1% of your budget, Ian, and I'll cut your ED attendances by 20%, you might say, where do I sign? But at the same time, I'll also save you some lives. And you'd ask, well, what is that? Well, actually, there is a capability out there that's done RCT trials at scale that does exactly that. And that's about prediction at the personalized level of what your risk is of attending ED within the next 6 months when we can do something about it, coupled with remote health coaching to a subset of those. And it's been demonstrated to achieve between 10 and 20% reductions in ED when used at scale. So there is progress being made on that innovation. So it's currently being built up in northeast London, but it's really slow. It's really glacial for a capability that's been around for about 14 years. So you have to ask yourselves, why? Why is that the case? Well, I thought I'd do a little bit of a thought experiment, which is, if you wanted to organise things in the NHS to minimise the market for innovation, what would you do? And I'll give you my 3, and you can think about yours. So the first thing I'd do is I'd divide the money between primary care and secondary care, because that way, innovations which cross pathways don't have a natural customer. And to be honest, a lot of innovations that have a lot of impact do cross pathways. So if you divide it there, that's a very effective way of reducing the size of the market for innovation. The second thing I'd do is I would make it really difficult to manage money over timescales. So with things like balance sheet constraints about capital spending limits and inability to borrow, etc., because that will rule out another class of innovations from having a natural customer, the innovations that need more than 12 months to pay back, which frankly is an awful lot of them. And the third thing I would do is I would try really hard to make it impossible to fairly ascribe accountability to anyone in the system. And that's quite a difficult trick to pull off at every level in an organization. But the way you do it, because to have accountability level, you need to have control of the money, you need to have authority to act, you need to have ability to act, and you need to have performance management capabilities. You need to do all those four things at the same time. So what you might do, for example, if you wanted to make sure no one was accountable, is that you would give systems the money, but no ability to act. You give the regions the ability to act, but none of the money. You give providers some of the money and some of the ability to act, but not all of it. And you would make really sure, what you would do is you would create massive uncertainty at all levels as to who had authority to act. But you would make everyone certain that they were responsible for performance management. So, and it's easy to criticize from the outside. And I think what's happened in the NHS is, for various reasons, sometimes really good reasons of financial control, we've evolved a situation where we really don't have clear accountability at every level. We've evolved a system where we can't manage money over multiple timescales, and where we split these budgets across pathways. And I think they all severely limit the market for innovation. So what then of the view that there's crying demand, but the issue is all about supply? Well, I've come to think that it's the reverse, that actually there's very little demand for innovation. And to think that there is to confuse need with demand. And the experience of entrepreneurs is perhaps better understood as kind of pushing water uphill, rather than being pulled in by the kind of demand that will allow no supply impediment to stand in the way, which is what we want. So why does all this matter? Well, I think it matters because beliefs affect behavior. So if you think that the issue is about, the priority is to increase the appetite for risk, then what you will end up doing is focusing on the absolute risk of change and not its risk relative to what we're already standing on. And therefore, you won't manage the total risk of the system. If you think that letting 1,000 flowers bloom is the right way of innovation happening, you will spend an awful lot of money on low-scale, non-replicable, locally tailored, and disconnected innovations which will not deliver and will take the money away from those which could. And if you think the issues are all supply side, then you'll try and fix all the supply side issues and you'll still find that nothing's happened because the fundamental issue is lack of demand. And what would happen if we were to invert those beliefs, if we were to sort of look through the telescope the other way, and to believe that essentially that our golden rules are a bit different. The golden rules were get your risk appetite down, stick to the best planting plan, top down, and pull, don't push. Well, I think it would look like the large-scale transformation program of work that London is initiating at the moment. And UCL Partners has been working with London to try and design and set up a very ambitious program of work. It's got a few features which I will very briefly go through because I know my time is coming to an end. It starts with a very clear top-down aspiration for where do we want activity to be. And specifically, it's about putting more capacity at the front end so that half of what's in general practice at the moment could be done in a different way, freeing up GP time to focus with secondary care colleagues on proper integrated care to keep a third of activity out of hospital setting, allowing, given what's fixed and not fixed in the hospital's accounts, allowing a quarter of secondary care costs to be redeployed further upstream to prevention, detection, and primary care, And if we do that properly, there's good reason to believe that we could increase healthy life expectancy in the long term by a fifth. So even I, Patrick, know that that is the harmonic sequence. I remember that from maths. So a half, a third, a quarter, a fifth. It has a model of care that it's starting with. So it's already got a view about where we want to end up, which combines a number of fronts which are intended to work together. So those include risk analytics at the personal level for all Londoners. It includes a much bigger functionality for the NHS app, so it can both provide better outreach, better support to self-care, and better routing of people to the best way of accessing care. It includes new total London pathways for some of the higher volume specialties like eyes and vision. And it includes cohort outreach, where we don't wait for demand to come in. We identify high-risk cohorts and go out and provide new models to deliver to them. So rather than letting 1,000 flowers bloom, it's very much a very strict planting scheme that it's got in mind. Its working assumption is that all supported initiatives will be scaled to total London. So it's starting with a route to scale already. And London is, twice the population of Scotland. It's a big thing. That gives a big enough market for this to make sense to those who want to put their capital into it. And it's going to try and pool all the relevant transformational spend at the regional level so that the money, the ability to act, the performance management, and therefore the accountability can be appropriately held at the same level. And it's planning to use commissioning models that flex rewards according to outcomes in a way that we just don't do at the moment. And also to try and encourage local experimentation, for example, some in Ian's patch, about pooling secondary and primary care budgets to stimulate underlying demand. So as a result, I'm confident that if you take a different set of beliefs and you let those guide the way that you approach the innovation challenge, that we will end up with London and other large systems. I could mention Manchester, for example, which will really be at the vanguard of the reform of the NHS. Thank you.
The Harley Street Health District, the home of healthcare since 1860.